I am Feliz Garingala Molina, chairperson of this session. With me as co-chair is Dr. Jeanette O'Malley, who will introduce our three speakers. Infectious diseases is very exciting and challenging field, and undeniably very broad in scope. In our individual patients, we do not deal with a single organ system, since infections can occur anywhere from head to foot. Host factors such as genetics, innate host immune defenses, age, and underlying non-infectious disease conditions create important impact on the likelihood of an infectious process to occur, response to treatment, as well as prognosis. This session will focus on three special populations, namely the elderly, the critically ill, and the diabetic. The main objective is to discuss the pathophysiology of aging and diabetes, as well as the role of microbiota in critically ill, as these relate to occurrence of infection and the clinical implications of such relationship.
Good morning, everyone. Today we will have three distinguished doctors to present, and in the interest of time, we ask that you hold your questions until all speakers have finished their presentation. You may also submit your questions through the MECA app. The username is your email, and the password is PSMID18. So we proceed with our first speaker. She is a professor of the UP College of Medicine and a director in the Institute on Aging, NIH UP Manila, as well as the vice president of the Philippine Foundation for Vaccination. Let us all welcome Dr. Shelley de la Vega.
Good morning, everyone. I again thank the organizers and scientific committee of this PSMID convention for including the topic of senescence, because all of us are aging. But for the topic today, we are going beyond immunosenescence. And as mentioned by Dr. Pineda Mercado a while ago, there are many factors beyond the immune system that affect the response of older persons to infections. So let's start now with okay, next slide. Next slide, please. All right, so the objectives of this talk is to first recognize that the Philippines is aging. That is one very important factor that we need to consider in planning our programs and policies, no? Not just for older persons, but many aspects such as aging, infections, vaccination, for example. Now, I'd also like to compare aging versus senescence, because these are two related but different terms, no? That we need to understand. And then go to immunosenescence, which many of you are probably familiar with. Beyond the immune system, of course, are many challenges that affects the older person's response to infections. And then we will discuss the clinical implications of these changes to particularly three disease conditions and one program concern, which is vaccination. Okay, so the population is getting older, no? If you look here, we are now about 77% old. So there are 7 million older persons in the Philippines, but in a few years, no? Particularly in 2050, we will be practically almost 30% old. All right, so based on the 2015 census of populations, from 7.5 million 60-year-olds, by about 2030 or 2035, that number would have doubled to 14%. So looking here now, we need to prepare for that eventuality when the Philippines will now be like Japan is now. Now, we are slowly aging, but according to our friends in the Population Commission, the Philippines is now entering that phase of slower growth in the number of infants being born. So we are now in the low fertility rate, no? But we're still being replaced. The older persons are still being replaced. We still have a lot of women giving birth to children. If you look here at the Philippines' leading causes of death, we know that non-communicable diseases now constitute most of the top 10, but looking at that list, pneumonia, infections such as influenza, and probably even COPD are definitely related to infectious diseases. All right, so how do we define aging? So aging is the accumulation of changes responsible for the sequential alterations that accompany advancing age and the associated progressive increase in the chance of disease and death. In contrast, senescence is something that happens with aging that predisposes us to increasing incidence of death. We age through various ways, from complex interactions of genetics and environmental factors, from genetic control issues, accumulation of damages by free radicals, cross-linkages of macromolecules, and somatic mutation. So senescence is that phase in the lifespan which is associated with an increased probability of dying as a function of time, no? So we do not die because of senescence. All mammals senesce because that is intrinsic and inevitable to us. Only worms probably will not die, and some Drosophila flies will not senesce, but definitely mammals will all senesce. So when you hear the word senile, it really is that phase in the aging process that is now associated with dying. Okay. Now, there are some principles of aging that I'd like to discuss with you. One is that some physiologic changes alter the appearance of disease, so that the symptomatology of pneumonia may be different, no, for older persons. Instead of having fever, they may just present with anorexia, no? Instead of shortness of breath, they may just feel dizzy. So there are many symptoms that are not necessarily as we learned it in school for sepsis or pneumonia. Now, one other physiological principle is that loss of function may not be apparent until the body is subjected to stress. So you may feel young now, but once you get a cold or a bad infection such as pneumonia, then that is when you will feel really old. And we now know that more older persons are really respond differently to pneumonia, even if they are given antibiotics. Now, one good principle that I'd like you to remember from this lecture is aging is a very heterogeneous experience, no? The older we are, the more unlike each other we become. And there is no one description of what an old person is. For example, we have young olds who are between the ages of 60 to 75. Young olds are generally healthy, vigorous, active, and vital. Many of you who are in this room are probably in that age group. And then, of course, we move on to the middle old, or the old, which are between the ages of 75 to 85, and that's when they become frail, more sickly, more prone to complications of diseases such as pneumonia, and when they become dependent on others in their activities of daily living. This is the group that we need to focus on. And of course, the oldest old, above the age of 85, are mostly frail and dependent. It's very rare that we see someone who is still very active. But I do see patients such as this 90-year-old patient of mine who came to my clinic asking me to help him to become vital again. So there are a few of them like that. All right, let's go to organ-specific aging. And this is really what immunosenescence is all about. Okay, the immune system does change as we age. There is reduced cell-mediated immunity. There is blunted IgG and IgM response following primary antigenic stimulation or re-challenge, such as when we give vaccines. There is a reduction in antibody response to infection or vaccination. And there is a reduced supply and responsiveness of T cells. I will discuss the implications of that later on. Okay, non-immune host defenses are also changed with aging, such as chronic diseases. Many older persons have more than one disease, no? Multiple morbidities, disabilities that predispose them to infection. An example is, for example, Parkinson's disease that alters their gag reflex and therefore makes them prone to pneumonias, especially the aspiration type. And then, of course, many older persons use multiple medical medications such as steroids, cytotoxic agents, H2 blockers, and sedatives. When they are hospitalized, they may be subject to instrumentation such as catheters, urinary catheters, and some of them may have had knee and hip replacements, no? That predispose them to infections in the joint. And of course, being in the hospital itself is really a challenge to older persons. Being in a nursing home also predisposes them to having infections that are beyond the community-acquired infections. Now let's look at normal aging and swallowing. Salivary flow is reduced in older persons, chewing is slower, and there is a tendency to hold the food bolus in the mouth, pocketing the food in their mouth, especially with dementia. And then there is a drop in the laryngeal position so that the act of swallowing is actually slower and not necessarily at the right time. However, despite this, many of our older persons are not prone to dysphagia. No? Now, if we look at certain conditions associated with dysphagia, we have CNS conditions such as stroke, Parkinson's disease, progressive supranuclear palsy, dementia, especially of the Alzheimer's type, neoplasia, and of course, oropharyngeal effects of drugs, as I mentioned earlier, extrinsic masses and neoplasia, and diabetes in particular. Now, dysphagia in Alzheimer's disease is quite interesting. The cause is not clear. No? Sometimes the person does not really know how to or when to swallow the food in his mouth. So they keep on chewing, they pocket it there, and by the time they want to swallow, the food is no longer able to go down the throat appropriately. Now, also, the level of alertness of a patient with dementia may be very low, so that they may be sleepy at the time when you ask them to feed, and that can be very dangerous. And of course, apraxia in itself is the inability to follow the usual steps of putting food in their mouth, chewing and swallowing. And other issues may also be involved in Alzheimer's disease, anorexia from some of the effects of the CNS lack of acetylcholine and other neurotransmitters. Some of the drugs for Alzheimer's, for example, can lead to anorexia. They may have depression on top of dementia. And of course, caregivers. If the caregiver is already too stressed, they might not be able to focus on hand-feeding the older person with dementia. How about drugs? In particular, we have to be aware of neuroleptics. CNS agents, antipsychotics would be a prime example, and some antidepressants, because they really can cause extrapyramidal side effects that are like Parkinson's disease. They can dry the mouth, but fortunately, these are reversible. Now, there are cultural and psychological barriers to the appropriate diagnosis and management of older persons. Ageism, for example, if an older person is just quiet, no, and maybe not wanting to eat, sometimes they may be told that, hindi, walang sakit si Lola, no, nag-umaarte lang yan, di ba? Umaarte lang yan, tahimik lang siya, hindi, walang sakit yan. But yung pala, pneumonia na pala. So that can be from ageism. And of course, when there are multiple health professionals in charge of one older patient, they may not necessarily be talking to each other. So it can make for a very complicated case. There, of course, are other health providers that are not professionals that may give the inappropriate diagnosis. And we know that a lot of older persons love to use herbal products, etc., that may not necessarily be of benefit. And of course, many older persons now have not really reached that age of education. So, what are the clinical implications of aging or senescence to infectious disease? Let's take the case of tuberculosis. Now, sometimes tuberculosis is a challenge. No, not sometimes, but always a challenge. When we have a person with tuberculosis, there's always this question of, will we treat? The side effects of the drugs are too much. Maybe we should not treat. But you have to treat, especially if that person lives with family or in a nursing home, right? So immunosenescence, limitation of macrophage activation, reduced natural killer cytotoxic capacity, decrease in interleukin-12, decrease in interferon gamma are all that predispose persons with tuberculosis to worse disease. No? Now, in the Philippines, looking at the recent study and this graph from WHO, we have a higher incidence and prevalence of tuberculosis among the older age group. When Dr. Lansang and Dr. Alexandra finished their paper, one of the things they mentioned to me is, Shelley, we really have to look at the aging population with tuberculosis because many of them are positive, they don't know that their sputum is positive, and they have not sought treatment. But also because of treatment failure, no? There is treatment failure. So there are some studies done outside of the Philippines on tuberculosis, and this just highlights the variability of tuberculosis and its public health impact. No? In Korea, for example, they say that their smear and culture negative conversion rate was 100% when they treated them. Ang galing naman. It's a little bit baffling because in some other countries, the cure rate is not that high. No? Conversion rate is not that high. And so in Korea, they were saying, even if the elderly have immune-compromising comorbidities, let's treat. No? These are not obstacles to treatment. But if you look at other countries, such as Hong Kong, they say that the prevalence is high and it's unclear whether poor health of the residents is the major contributing factor. In India, the cure rate or conversion rate after treatment is lower, and it's probably similar to that in the Philippines, our experience here. Because the cure rate in India is 69.2% versus 8.7% young versus geriatric TB patients. And their exclusion rates in their DOTS program is also higher among older patients with TB. So those are the things that we also have to watch out here in the Philippines, aside, of course, from the known adverse drug events of INH, rifampicin, and ethambutol. But nevertheless, if it needs to be treated, we need to treat, and just watch out for the side effects. How about vaccines? This is not a lecture on vaccination, but of course, many things about aging alter the response of older persons to vaccination. Immunosenescence, comorbidities, cardiovascular and respiratory changes that I mentioned. And of course, in particular, influenza. The efficacy of influenza, of the vaccination against flu, is a little bit lower among older persons, 50 to 60% compared to 70 to 90% vaccine efficacy in the elderly. But nevertheless, it's still good to vaccinate against influenza. There are some diseases that are also altered in terms of their vaccine response and their need to vaccination. For example, pneumococcal bacteremia is quite deadly in the elderly and definitely one reason why we need to vaccinate against pneumonia. And of course, herpes zoster, because of advancing age and impaired cell-mediated immunity, we have a higher risk of herpes zoster, varicella zoster reactivation in the form of herpes zoster. Vaccines are effective because this is really the only chance of older persons with declining immune responses. But if we look at vaccination, it's not just important for the older person to know, but it is important for us to prescribe vaccination to our older patients, because it's when the doctors prescribe it that they start to take on the vaccination. So there are many misperceptions on vaccination among older persons, therefore we need to advocate for vaccination. Now, how about HIV? This is a little bit unique, no? Because a lot of HIV patients or persons living with HIV, especially in the United States, where antiretroviral therapy is available, a lot of them are already aging, no? And this is a result of ART, no? Survival benefit. And it's also linked to the UNAIDS 1990 targets, wherein 90% of persons living with HIV in a community or country are aware of their status, 90% have initiated ART, and 90% of those in ART achieve durable viral suppression. So that what they are talking about now is that healthy aging is probably the fourth 90. Okay? Healthy aging is now the fourth 90. So we need to not just focus on HIV suppression through ART, but focus on their lifestyles. Because if you look at this slide, now many older persons with HIV now have non-communicable diseases, and they are now suffering in high-income countries from diabetes, osteoporotic bone fractures as a result of ART, myocardial infarction, frailty, arthritis, and cancer. Which is really not so very different from the experience of the general population. So challenges in older persons living with HIV include non-communicable diseases, adherence to lifelong HIV treatment, coordination of care, no? Social isolation continues to be a challenge, more so when they are old with HIV, because by the time they are old with HIV, they may no longer have the support system that they relied upon when they were young. Substance use and abuse, depression, of course, and stress, and of course, dementia. And I'm not talking about HIV-associated dementia, but dementia of aging. No? When they age, they also will be prone to dementia. But don't forget, healthy aging is still the message that we need to forward to our persons living with HIV. So in essence, we now have heard that the Philippines is aging along with the rest of the world. And in a few years, we will be probably 10% old. And 15, 20 years from now, the number of older persons in the Philippines will double. And that poses a great challenge to infections, in particular, to vaccination as programs, because we need to now start providing more older persons with vaccines. No? And the law, RA 9994, says that all older persons, indigent in particular, should receive the free flu and pneumonia vaccine. I just came from a meeting with the DOH, and we were thinking, is that appropriate to just limit vaccination to indigent older persons? Maybe we should expand that benefit to all older persons and try to see, because we really need to provide vaccination for older persons for the rest of their lives. And of course, we need now to refocus our attention on how to face the challenge of tuberculosis among older persons in the Philippines, because a lot of them are not accessing the DOTS program, a lot of them are not being treated for fear of INH toxicity, and of course, just being aware of the possibility that they have tuberculosis. No? In the same way, we need to look at our persons living with HIV, because they are getting older. I asked a few of our friends, IDS friends, what the age of their oldest HIV patient is, and one was about 68. But in the United States, there now are 80-year-olds living with HIV, and we need to help prepare them, not just for HIV, but for all the things that are associated with aging. So thank you very much.
Thank you, Dr. De La Vega, for that very knowledgeable talk. Indeed, many elderly patients present with non-specific clinical symptoms. That's why, with a very high index of bacterial infection, hit hard and early is the most oftentimes the therapeutic principle in this population. So our second speaker is an active consultant of St. Luke's Medical Center Global City Institute of Digestive and Liver Diseases in Taguig City. She is also the head of the Gut Microbiome and Fecal Transplant Institute of Digestive and Liver Diseases at St. Luke's Medical Center Global City, and also the head of the Patient Safety and Quality Assurance Institute of Digestive and Liver Diseases at St. Luke's Medical Center Global City. We welcome Dr. Alexandra Laya.
Good morning, everyone. I am delighted and honored to be here in front of you today, and just as delighted, maybe unrelated, because of last night's win. Yay! We are going to talk today about the effect of the microbiome in critically ill patients, and I can start as soon as I have my slides. Perhaps we can just use our slides there in the back. Silang files. Tanggalin ko muna. Okay, so all that excitement built up, I'm sure you can't wait to listen to the lecture. So today, what we will discuss, how do I do the slides? Okay, we're going to discuss the human microbiome. We are going to discuss how it is altered in critical illness. We will also look at ways to modify the gut microbiome to restore symbiosis. And to look into that into detail, what we are going to look at are the outcomes of three diseases. And it's listed as C. difficile infection, ventilator-associated pneumonia, and briefly, we are going to talk about sepsis. So some definitions. When we talk about microbiota, we often think about the microorganism, the bacteria, the fungi, the virus. But when we think about the microbiome, we are talking about the collective genomic material found in all these microorganisms, as well as ourselves as the host. Now, there are 10 times more bacterial cells than there are human cells. And there are over 100 trillion microbes in our guts. And so if you think about it, the aggregate volume of all these microbiota is around 5 pounds, which may not seem much, but if you put it into perspective, our brains weigh 3 pounds. And so we are more bacteria or microbes than we are brain. And so it is very impressive to think about the concept of the microbiome. Now, we are so lucky because for the first time, we're able to study the microbiome using culture-independent pathways. Now, these culture-independent pathways allow us to actually sequence the bacteria and their relative abundance in the sample. Because of this ability, then we have the capacity of doing more research, doing more studies to find out if this can impact us in our clinical practice. Okay, the microbiome. We all have our own microbiome fingerprint. So my microbiome is different from yours and is different from the one beside you. And the stability and the diversity of the microbiome are greatly influenced by a number of factors. Our age, how we were born. Were we born vaginally? Were we born by cesarean section? I mean, how much attention was placed on hygiene? Did we take antibiotics? Did we eat antibiotic-loaded chicken or something like that? So all of these things factor into your microbiome. Now, this microbiome that we have is generally established as early as 2 or 3 years of age. And although it varies throughout our lifetime, it's still generally dominated by 2 phyla, Bacteroides and Firmicutes. Okay. Now, there was a study in 2016 that looked at the microbiome alterations in critical illness. And what they did was, because this was an offshoot of the Human Microbiome Project, the initiative of the National Institutes of Health. And so what they did was they compared the microbiome of a sick individual as they entered the ICU and looked at their microbiome at their discharge, comparing them to those who have healthy microbiomes, normal patients. And so what they saw is there was a significant and rapid decrease in the health-promoting microbes. And so you can see there was a decrease in those blue swabs there. That's your Firmicutes. There's also a decrease in the amount of your green color, and that's the Bacteroides. At the same time, there's overgrowth of pathogenic organisms. Those are the red swabs. And so suddenly, you have an altered microbiome. Now, this alteration in the microbiome, this dysbiosis, has been associated with increased morbidity, hospital-acquired infections, multi-organ dysfunction, sepsis. And this is one of the studies that actually became a springboard for which the concept of, could we alter the microbiome to impact therapeutic benefit? So this is kind of the concept behind the microbiome alteration. So if all goes well, and if we are all lucky, we end up with a healthy microbiome. And when we are exposed to illness, whether it be surgery or trauma or infection, we develop what we call a pathobiome, a deterioration of the healthy balance, and we have all this dysbiosis that leads to adverse effects to the host. And so we wonder, could we modulate the microbiome? Can we alter it somehow so that we can reacquire a healthy microbiome? And so the thought comes in that maybe biotics can do that. So when I talk about biotics, I'm not talking about antibiotics, I'm talking about probiotics. So these are synthetics and probiotics that are ingested by an individual, either in individual strains or a combination of strains, to provide a health benefit. Most commonly, we hear this in association with diarrheal illnesses or gastrointestinal symptoms, bloating, etc. Now, the full spectrum microbiota, or your FMT, the fecal microbiota transplantation, this is actually where you infuse a fecal suspension of a healthy individual into the gastrointestinal tract of a sick individual. Okay, so it doesn't seem fair, but this animation will try to compare synthetics or probiotics and the fecal microbiome transplant. Basically, the important part to highlight here is that your FMT, it recreates your normal gastrointestinal microbiome, and so you transplant the entire spectrum, not just the microorganisms, but we know there's something else in our poop that provides some benefit. We just don't know what it is. In comparison to probiotics, which actually is just ingestion of a fixed, finite, very specific set of bacterial strains. It's the drop in the bucket compared to the big kahuna. Okay. Now your probiotics or your synthetics are commercially available. And it never really was difficult to get approval to put it in the market, because actually the organisms in these probiotics have been used for centuries in the food industry. And so our yogurt, Yakult, kombucha, all of those things are basically what these probiotic supplements are also trying to aim for. In contrast, a fecal microbiota transplant is still considered an investigational new drug. So it's a drug, it is regulated, and can only be used in situations of clinical trials. But actually, the US FDA has granted approval for its use on the condition that it is for the management of C. difficile infections. So we're going to move on to one of the three topics that we will talk about. The first one is about recurrent, refractory, and severe C. difficile. So what's the problem? I mean, why do these people get recurrent disease? And so this study went back to look at their microbiome. And on this side on the left, it's your control group. The big red swabs, the red, the green, that represents a healthy microbiome. This is your Bacteroides and your Firmicutes. Now, among patients who have suffered one episode of C. difficile infection after they recover from their illness, if you look at their microbiome, it's still very similar to someone who has never been sick with C. diff. It's those you see who have recurrent disease after a second, third, or fourth infection. Suddenly, you see a totally different picture. You lose the combination of the greens and the reds, and you have dominance of organisms that used to be in the minority, and now they're the majority. This graph on the right looks at diversity. And among patients who are healthy, and again, even those who have suffered first episode of C. difficile, they have nice and diverse microbiomes. Those who have recurrent disease, they're the ones that they just can't get that diversity back. And so this is why they get recurrent disease. In 2013, the New England Journal published the first randomized trial comparing three groups: fecal microbiota transplantation delivered via nasoduodenal tube, compared it to a group that was given vancomycin, or a third group that was given vancomycin plus bowel lavage. Now, if you look at these numbers, it's not very big, 12, 16, 13. These are small groups, but when you look at their results, it was actually very staggering. They actually stopped the trial because of such good results. Patients found an 82% cure rate after the first infusion of FMT. No diarrhea, C. diff negative after one infusion. In comparison, and so those who did not respond to the first infusion, they got a second transplant, and the cure rate went up to nearly 94%. Now, this is in comparison to the other groups, the vancomycin group, 30%, versus vancomycin with bowel lavage, 23%. So, huge difference. Now, this is another randomized trial. This time, it is delivered by colonoscopy, because the Netherlands study was by nasoduodenal tube. So this is through a colonoscopy, and it's the same thing. The cure rates are amazing. On the FMT arm, you have a 90% cure rate. On the vancomycin alone arm, 26%. So around this time last year, we had a successful pioneering experience at delivering a fecal microbiota transplantation in a very sick lady. She was 71-year-old, and she had severe C. difficile infection with sepsis and pseudomembranous colitis. She did not respond to the standard treatment of vancomycin either by mouth or delivered rectally or with IV metronidazole. And so this is her colonoscopy. Can we play that colonoscopy, please? So on her colonoscopy, we found her colon. That's not her colonoscopy. That's not the colonoscopy. So her colon showed, really swollen and edematous mucosa. Now you can see it playing. There were areas of friability. There were yellowish pseudomembranes. It was a sick-looking colon. So she underwent fecal microbiota transplantation from a healthy screened donor, and immediate dramatic resolution of symptoms, and was discharged within 48 hours. On the right here is her colonoscopy 8 weeks after that fecal transplant, and if you can also play the video on the right. Completely healed, asymptomatic. Her symptoms continued to be, non-existent. She was very healthy. Now, fast forward a year later, she had several UTIs and had some antibiotics for that. No recurrence of the C. difficile, so durable implantation. Okay, so let's change gears. Now we're going to talk about ventilator-associated pneumonia. Now, there have been many trials looking at the role of probiotics for the treatment and prevention of ventilator-associated pneumonia. Now, for us to grasp this concept, we have to realize that it starts in the mouth. And so, having an endotracheal tube or a tracheostomy tube allows direct entry into the lungs, and so you can have direct implant of bacteria in that route. Although we know that hematogenous spread also is possible, obviously, this kind of system begins in the oral cavity. And so there have been many trials looking at the potential protective effect of probiotics against the development of VAP. And a systemic review and a meta-analysis was published in 2016. And they looked at the efficacy of probiotics and symbiotics, which is a prebiotic and a probiotic, on the clinical outcomes in critical illness. And they aggregated 30 trials with nearly 3,000 patients. And what they found was, when they looked at these outcomes, they found that there was a reduction of overall infection by around 20%. There was also a reduction of ventilator-associated pneumonia, around 26%. and also a decrease in the antibiotic days, although it didn't seem too much. It was just 1.1 days. But it's very interesting. You know, there was also a subgroup analysis in this particular trial that they noticed that among patients who received probiotic supplement, including Lactobacillus plantarum, there was a 30% reduction in overall infections. There was an interesting trial. This time it was a randomized controlled multi-center trial in China in 2016. It was open labeled. They involved 235 adults whom they expected to be on the mechanical ventilator for at least 48 hours. And they used a combination of Bacillus and Enterococcus faecalis, which is a little interesting because these are not the typical organisms that we would have in our commercial probiotic supplements, but that's what they had and that's what they used in this particular study. Now, what they found was there was a significant difference when it came to onset of ventilator-associated pneumonia, meaning they had more days not having pneumonia. And they also looked at the amount of gastric colonization with potentially pathogenic organisms. And they found that there was less chance of having colonization of the bad bugs. And so they continued to have good bugs because of the intervention, which was the probiotic supplement. Now, this trial, again, it just highlights that the mechanism that works behind the use of probiotics, we're just learning about them. And what the authors of this study proposed was that when you alter the gut microbiome to maintain more of a normal, healthy microbiome, as opposed to having a dysbiosis or a pathobiome, then you have, gut integrity, you have gut barrier function, you have good immune modulation, you have action against pathogenic organisms. So interesting study. Now, a cost-benefit analysis was also studied. In 2015, this group of authors figured that 3 things can decrease the risk of VAP, which is the suctioning of the endotracheal tube, the IHI ventilator bundle, which includes an elevation of the head of bed, sedation weaning, etc., and probiotics. Probiotics was included in that triad. Now, numerous studies have shown that there is a trend towards the preventive effects of probiotics in ventilator-associated pneumonia. It's also appealing. The cost-benefit is very good. However, all those studies that have been available have some degree of bias. There's single-center studies, there are small studies, and we also have some limitations on interpreting these studies because these studies have such varied protocols. So it's difficult to infer from that data. And we're going to get to the last couple of slides here. I'm just going to mention one study about sepsis. And so a randomized symbiotic trial to prevent sepsis among infants in rural India. This was in 2017. It was a double-blind, placebo-controlled RCT. It involved over 4,000 infants over 149 randomly chosen villages. And it was in the region of India where infant mortality was actually very high. So the intervention included a symbiotic, which was Lactobacillus plantarum, plus fructooligosaccharides. So it's a symbiotic given to newborns for 7 days. And they looked at their outcome. The primary outcome was death and sepsis. And this is the table of their results. And the important thing to note here was there was a significant reduction in their primary outcome of death and sepsis, and their calculated number needed to treat was just 27. And also they found there was an overall decrease in sepsis, whether it be sepsis with cultures that are positive or culture negative sepsis or sepsis related to lower respiratory tract infection. They did not identify any adverse events. And the conclusion of these authors include that neonatal sepsis in developing countries could be effectively prevented when you use a symbiotic that contained Lactobacillus plantarum. And so actually this lactobacilli was also the same strain of organism that we talked about earlier, the one that also showed a decrease in VAP. So in conclusion, there are significant alterations in our microbiome when there is critical illness. And our understanding of this concept continues to change and continues to evolve. But fortunately, with the advent of these new sequencers, we can study it more accurately. There is considerable potential in using biotics in the modification of the microbiome so that we can mitigate disease. You saw the dramatic effect of a fecal transplant for C. difficile infection. It was just astounding. But when it comes to C. difficile, it's a little simpler. We know what the problem is. The problem is C. difficile and dysbiosis, and so by giving them the fecal transplant to fix their dysbiosis, they are cured. But when it comes to sepsis or VAP, what causes that? I mean, we don't know. It's too complicated. And although there is potential for the use of probiotics and symbiotics for the prevention of VAP and sepsis, it's not a home run, just like with fecal transplant and C. diff infections. So definitely, we have to realize that there is a need for more studies here because we are just learning about this new aspect, and we need to embrace it and move forward with it. And thank you very much.
Thank you, Dr. Laya, for that well-informed and very interesting presentation. So you see, our own microbiota could often be our body's best buddies. So as we go on with our last presentation, our speaker is the Associate Active Staff and Vice Chair of the Infection Control and Antimicrobial Stewardship Committee of Davao Doctors Hospital. She is also a visiting consultant of several medical institutions in Davao. She is also a chair of the Antimicrobial Stewardship Committee at BIHMI and MMC. Ladies and gentlemen, let us welcome Dr. Kathryn Roa.
Good afternoon. So I'm sure we have encountered a lot of patients in our practice who are diabetics. And usually they come again and again. No? Masuki na. Kasi palagi naga-UTI, naga-pneumonia, naga-cellulitis. No? That's the story of their lives. So the point of this lecture is, since med school, we've always been told, right, that if you're diabetic, if the patient is diabetic, there's a problem with the immune system, the patient is more prone to having infections. But really, my question here is, what makes that so? What is it in the diabetic person that makes that person susceptible to infections? And I think the more important question there is, what can we do? What can we advise the patient to change the way his cells behave? So that is the point of this discussion. So risk of infection, bingo na, di ba? So there's no question about it. The odds ratios here, so this is all are increased in favor of the diabetics. kahit anong infection pa ang isipin mo, winner talaga sila na subgroup. Okay, so these two tables show us the figures, the odds ratios for cohort studies. No, so all of the infections here, the odds ratios are more than 1. Okay. For case control studies, it's the same. So again, everything crosses 1. The table on the left shows us the unadjusted odds ratio, or the crude odds ratio, and the one on the right shows us the adjusted odds ratios for confounders. So the same, whether you adjust or not, the fact remains for all types of infections, winner talaga ang mga diabetics. So this one is after, so that meta-analysis was done, I think, in 2017. So after that meta-analysis, these two studies came out this year. So in a Canadian study, the adjusted odds ratio was 1.21, comparing over 1,500 diabetic patients, and 22% of them on insulin, compared with matched controls who were non-diabetics. And association was found for skin and soft tissue infections, genitourinary, gastrointestinal, and respiratory. But no association was found in the head and neck infections, musculoskeletal, and viral infections. This one was a retrospective cohort study in England. Again, the incidence risk ratio for any infection was higher in the diabetics, compared with age, sex, and practice-matched controls. So the same. IRR, 1.47 for type 2 DMs, especially for bone and joint, candidiasis, and cellulitis. And actually, there's a very interesting mechanism on what makes them prone to candidal infections, and we'll talk about that later on. TB in DM. This is also very interesting. Diabetes increases TB risk by 1.5 to 7.8 times. That's why right now in our TB CPG, what we're saying is that if you have patients who are diabetics, you screen for TB. If you have TB patients, you also screen for diabetes, right? Relative risk was 3.11. Odds ratio of MDR-TB in diabetics is 2.1. So they're more likely to have multi-drug resistant TB. Why is that? Because there's higher risk for treatment failure in diabetics. So this one is for a combination of treatment failure and death. Risk ratio is 1.69 compared to non-diabetics. And purely for death as outcome, risk ratio was 1.89, and relapse risk ratio of 3.89 in favor of the diabetics. So host factors. We have hyperglycemia-related impairment of immune response. So what happens? There's depressed neutrophil chemotaxis and adherence to vascular epithelium. There's also problems with phagocytosis. There's problems with intracellular bactericidal activity, opsonization, and cell-mediated immunity. And really, these are the ones that we will look at later on how we can change the behavior of those cells. In melioidosis, PMNs from diabetic subjects exhibited decreased phagocytosis and chemotaxis, and were defective in the release of extracellular DNA, also known as neutrophil extracellular traps. And this is the one that enables the neutrophils to act against bacteria. So in TB, diabetic monocytes showed impaired chemotaxis again, but this one is really more specific on the, it gives us more of an idea on how the cells behave in the presence of particular organisms. And also, the alveolar macrophages were less activated with decreased hydrogen peroxide production. Or that's what they call the respiratory burst response of the cells when they try to kill bacteria. So, what else? We have reduced T helper cell function. There's also problem with TNF alpha and TNF beta, and also a decrease in interleukin production. And the thing with this is that these are intrinsic cellular defects of diabetic cells. So maybe later on, when we start talking about how do we advise our patients, we really should think about, even if we try to mitigate the different, some of the abnormalities in the immune system of our diabetic patients, there are really some intrinsic defects that we cannot do anything about. Macrophage dysfunction results in impaired production of reactive oxygen species, again, in phagocytic and chemotactic function. And for staph, which is, a lot of diabetics are colonized with staph, there's impaired killing function of diabetic neutrophils. And this is found in all studies using staph as the representative organism. So, host factor, again. Vascular insufficiency enhances growth of microaerophilic and anaerobic organisms. And this is why, when we think of bacterial infections in diabetics, we always think of a polymicrobial milieu, right? It's because of this. So aside from they being colonized by staph, they being more prone to gram-neg bacteria, they're also prone to having anaerobic organisms because of the vascular insufficiency. Why is there vascular insufficiency? It's because the red blood cells become sticky, and as they move through the capillaries, they get stuck, and thus there is a relative hypoxemia in the vascular bed. So also here, there's depression of the oxygen-dependent bactericidal function of leukocytes, and also impairment of local inflammatory response and antibiotic absorption. It's because of the vascular insufficiency. So when we tell our patients, we need to give your antibiotic via intravenous route, because we cannot guarantee that the antibiotic will really go to, especially in the smallest capillaries, right, in the periphery. Another host factor is sensory peripheral neuropathy. And this one, once a patient has sensory peripheral neuropathy, this is why we get a lot of patients with diabetic foot, because they get injured in their feet and they don't feel it, right? They only feel it once. It becomes swollen, huge, warm, and cellulitis has set in. Autonomic neuropathy predisposes our patients to having urinary retention and stasis. So when we have our soaking diabetic patients who always come back for UTI, this is one of the reasons. Yeah? Also, we mentioned this already, increased skin and mucosal colonization. So diabetes and specific infections. For pulmonary infections, there's increased risk of aspiration secondary to gastroparesis, which is, again, part of the neuropathy, right? Autonomic neuropathy in diabetes. There's diminished cough reflex and also disordered sleep patterns. Also, there's lung abnormalities involving microangiopathic changes in the basement membrane of the pulmonary blood vessels and the respiratory epithelium. And also there's also a problem with the glycosylation of tissue protein. For UTI, there's reduced sensitivity and altered distensibility of the urinary bladder due to autonomic neuropathy. We already mentioned that. Also, glycosuria can enhance bacterial growth and impair phagocytosis. So really, when we tell our patients, sometimes our patients will ask us, Doc, how come I always get UTI? One of my common answers there is, because you always offer buffet to the bacteria. And that is a true statement. It sounds like a joke, but it's a true statement. Because bacteria love sugar, right? And as long as there's glucosuria, really it's a buffet for them. Okay? You combine that with the autonomic neuropathy that encourages stasis, right? And you will really have the perfect setting for multiplication of the bacteria, So it's a bacterial party in the urinary bladder. This one is interesting. Candida albicans expresses a receptor-like surface protein for complement factor 3b. And this one, the thing here is that for phagocytosis to occur, there has to be the complement factor has to attach to the receptor, the proper receptor, for complement type of killing or complement-mediated killing to occur. But in this case, in the case of Candida, they express receptor-like surface protein. So the cells becomes confused, right? The human cells become confused. They're not able to recognize and attach the proper receptor, and thus phagocytosis is impaired. And also, Candida albicans also thrive in a high sugar environment. Also here is periodontal disease. Contributing factors involve high salivary glucose, low salivary pH, microangiopathy, and abnormal collagen metabolism. And the thing is, periodontal disease is one of those aspects of diabetes care that is often overlooked. And sometimes what we see is that a lot of diabetics have problems with their teeth. It's because there's not really proper dental care that's being done on these patients, which they should get. So, glycemic control. What's the relationship between glycemic control and infection risk? Long-term infection risk rises with increasing HbA1c. So optimal control, it's HbA1c of 6 to 7%. IRR there is 1.41. Poor control, IRR goes up to 4.7, right? So the worse your sugar control is, the more likely you are to have an infection. Euglycemic control, or blood sugar between 100 to 120, reduces the risk of or the incidence of chest infections in ICU patients. That's very tight. When you look at it, when you read articles on what's the optimal sugar control, sometimes, we get articles talking about what's the optimal sugar control to prevent post-op or SSI, skin and soft tissue infections post-op, right? And sometimes their targets are quite high. What? Less than 180, right? Anything less than 180 is acceptable. So that's quite high. But here, in this study, they said it's 100 to 120. So this one, so what happens? If you're able to control glycemia, what happens? Phagocytic activity increases after metabolic improvement. So there is hope. So, even if we say that, okay, the patient is diabetic, he has derangements in the immune system, there is hope. You will see later it's very difficult to achieve that, but there is hope. This one is very interesting, and this is the reason, most of the studies here are really mechanistic, because if we look at, RCTs and where the outcomes that are measured are death, or development of infections and things like that. That's where the glycemic goals become very wide, right? But when we look at basic science studies where they really look at the function of the cells, diabetic versus non-diabetic cells, that's where things get very interesting. So this one, myeloperoxidase, is a substance in the neutrophils that enables the cells to do oxygen-mediated killing of bacteria, fungi, viruses, and cancer cells, right? So that substance there is what makes it, enables it to do that function. So what they did here was they looked at myeloperoxidase ratios in neutrophils in patients with poor glycemic control compared to those with good glycemic control and compared to healthy controls, right? So what did they see? Poor glycemic control, that's 70 out of 100, It's quite low. Those with good glycemic control, it's 80 over 100. It's not as high as healthy controls or normal cells, which is 88. But 80 is, well, what they said was, between poor glycemic control and healthy controls, there's a significant difference there. So for as long as we're able to control glycemia in the patient, the function of the myeloperoxidase will sort of approximate the function of a healthy cell, a healthy non-diabetic cell. So, what is better glycemic control? Because that is the goal, the very difficult goal. HbA1c means you control both fasting plasma glucose values and post-meal glycemia. The thing here is that when a lot of us think about HbA1c, it's always, it's something that we do every 3 months, right? Because that's what it measures. It measures glycemic control in a period of 3 months. But what we should remember is that before we get to that 3 months, there's 90 days, right? And post-meal glycemia, you eat 3 times a day. Whatever your post-meal reading is, or glucose level is, that will influence your HbA1c 3 months from now. So they say the post-meal goal should be less than 140, 2 hours postprandial. See how difficult that is? That's close to normal. So how do you make a diabetic person eat so little to approximate the function of a normal, a non-diabetic person? So here, this is interesting. To be able to achieve, what's the goal for HbA1c? It's less than 7, right, for good control. How do you achieve that? Preprandial capillary plasma glucose should be between 80 to 130. That's, fasting in the morning, 80 to 130. Peak postprandial capillary plasma glucose should be less than 180. And really, 2 hours after a meal, it should be less than 140. Because this less than 180 is the peak postprandial level to get an A1C of 7. So you will see here the A1Cs, and to be able to achieve these A1Cs, you look at, you have the different CBGs, right? So for example, if your patient has an A1C of 8, that means that patient's mean plasma glucose is 183. So that's quite high, that's why it's 8. What else? For 7 to 7.49, mean fasting is 152. Mean post-meal is 176. So I'm showing this slide because I really want to stress that, instead of just thinking of the A1C that we measure every 3 months, because we cannot correct anymore. 3 months from now, we cannot correct the 90 days that has passed, right? We have already exposed the cells to hyperglycemia for 90 days. So how do we prevent infection? So for lung infection, vaccine is very important. And this is an interesting study because here they showed that vaccine efficacy was higher in diabetic patients. I was quite surprised with this study. And also, influenza vaccination prevented all-cause hospitalization. So that's for lung infection. For urinary tract infection, liberal fluid intake, post-voidal voiding, abstinence of, or decrease in the use of spermicide-containing products. So these are, just the regular advice that we tell our patients, right? This one is quite interesting because this is kind of new. For diabetic wound healing, especially for diabetic foot ulcers, hyperbaric oxygen therapy increases oxygen levels in hypoxic tissues, but it's very difficult to come by, right? It's, in Davao, we only have one machine, I think in the whole Region 11, we only have one machine. These doctors, they tried looking at normobaric hyperoxic therapy, where they give oxygen of FiO2 of almost 100 in a normal pressure setting. So you don't need the special hyperbaric chamber, you just need FiO2 of 100. But I don't know how to achieve that, right? Because if you only use a CPAP with a side flow of 15 liters, what is that? FiO2 of 80. So more than that, right? And this one was also quite interesting. Remember when we advise our patients with diabetic feet, we usually tell them elevate the foot, right? Because it decreases pooling of the, like edema and all the bad things that go with edema, right? But what they're saying here is that there could be benefit in foot lowering because it may augment tissue oxygenation. So that is something to think about. Now, so those are the other things, but let's go back to the most important part, which is the glucose control. So, again, right now, they said, articles will tell us that there needs to be more studies done on really what is optimal control. Because when we read studies, they always say, if you make the glycemic control too tight, you will expose the patient to hypoglycemic episodes, and that will make it, more difficult for the patient, right? But really, in terms of cellular function, mechanistically, for those cells to go back to close to non-diabetic function, it needs to be, we really need to approximate normoglycemic levels. So some studies would say, the typical high fiber, low glycemic index type of diet and all these things. But what was interesting was, they said for the cell to do its function, phagocytic function, it needs energy, right? Energy comes from glucose. So if the glucose is outside the cell, it will also impair cellular function. We need the glucose inside the cell for the cell to be able to do the phagocytic function. How do you get the glucose inside the cell, short of giving insulin? The most practical thing that I was able to read was walk after a meal, right? Walk after a meal. That will get the glucose into the cell, right? I'm sure, and that is, when we think about it, intuitively, it makes sense, right? Because how do you increase insulin sensitivity? Physical activity, right? And how do you make sure that after a meal, you don't really shoot up in terms of your post-meal glycemic level or glucose level? You walk, okay? So that is interesting. It's very, and I hope that there will be more studies on this later on because, when we educate our patients, it's important that we empower them, right? Even if it's difficult for them, at least, right, we tell them there is hope, okay? So I hope you found this topic interesting as, as I found it when I was preparing for it, right? Okay, so thank you very much. Have a great day.
Thank you very much to our three speakers, Dr. Shelley de la Vega, who presented that with the phenomenon of aging Philippine population, like the rest of the world, we need to look into, one, the vaccination needs of our elderly, as well as accessibility and availability of these vaccines for all elderly. Number two, special TB-related diagnostic and therapeutic issues. And third, about the aging HIV population and their infection-related and non-infection-related complications. To Dr. Alexandra Laya, we are thankful for her introducing the term dysbiosis in critically ill patients and the impact or promising impact of positive manipulation of the human microbiome to restore gut integrity and health in general. And finally, to Dr. Kathryn, who walked us through the host factors in diabetics which make them at increased risk for infection, and how good glycemic control go hand in hand with infection prevention and control. In the interest of time, we will forgo with our open forum, but I think it's okay to approach any of our speakers personally if you have any burning questions or concern. In deep gratitude, we would like to request our three speakers to please come up the stage. Dr. Shelley de la Vega, Dr. Alexandra Laya, and Dr. Kathryn to receive your certificates of appreciation to be presented by Dr. Mario Panaligan, President of PSMID, and our organizing chair of the convention, Dr. Marisa Alejandria. Thank you everyone for attending this second convention symposium, and you are now all invited to our lunch symposium.